Ladies and gentlemen, please welcome Senior Director of Faster Cures, Esther Krofa.
Hello, good afternoon. It's great to see such a lovely crowd. Thank you all so much for joining us today at the Milken Institute's Future of Health Summit. And in this final session, Walking the Drug Pricing Tightrope, Fostering Innovation while Maintaining Affordability. It's been an exhilarating and intense few days of debate and learning about many of the most urgent topics in medical research and public health. But we have saved the best for last, in my opinion. Thank you for staying with us through this program. As mentioned, I am Esther Krofa, Senior Director at Faster Cures. At Faster Cures, we work to accelerate medical research by identifying and addressing barriers that stand in the way of getting novel treatments to patients faster. The work that we do is focused on 3 areas: enabling patients to more easily participate in medical research, creating pathways to medical innovation, and advancing a better and high-functioning biomedical innovation ecosystem. The reality of the situation Faster Cures exists to address is stark. There are nearly 10,000 diseases affecting millions across the globe. Today, we have treatments for only 500 of them. Things have to change and change quickly. In medical research, there always seems to be a headline each week about an exciting new development, a new cause of hope for patients. And because of that, we all assume that when the time comes for us or those whom we love, medical progress will have caught up to where we are and what we need. But that isn't always the case. All kinds of roadblocks get in the way: lack of collaboration, misaligned incentives, lack of the right capital in the right place at the right time. The challenges are many and thorny. We can do better, and together we will. We want you all to be partners in disrupting the system and saving lives. That isn't an overstatement. Delays cost lives. We must be organized and mobilized because the alternative leads to bureaucratic and entrenched silos. We must look at the whole system and use our collective voice to demand better, especially when the cost of inaction is so high. HIV/AIDS provides us all with a compelling example. A highly engaged patient community challenged and catalyzed stakeholders to play a key role in addressing this disease. What was once a death sentence is now managed like any other chronic disease, but only for those who have access to these life-saving therapies. All our work to accelerate new science from the lab bench to the market will be for naught if patients don't have access to it. And affordability means nothing if there is nothing in the pipeline for patients to have access to. That's why the topic of this session is important to us at Faster Cures. We see what extraordinary things humans are capable of on the science side every day. We know we're capable of extraordinary things on the policy side as well. We are capable of reaching more than one objective, and we can encourage exploration and deliver on the promise of scientific discovery and make treatments affordable for all patients. We look forward to exploring how these goals can be achieved with our speakers today. And without further ado, I would like to introduce Senator and Dr. Bill Cassidy of Louisiana, who will be interviewed by Dan Diamond, the author of Political Pulse. Thank you.
Senator Cassidy, thank you for being here. Thank you, Dan.
I'm personally grateful because I've been fighting a cold for a few weeks. This is actually the most effective way to get an appointment with the doctor in Washington, D.C.
I am personally resentful, and do you mind looking that way?
It's not that contagious. Let's move to the topic at hand, which is not my sniffly nose, but the drug pricing packages in Washington, D.C., your involvement in them. House Democrats are pushing a package aggressively. In the Senate, there's a bipartisan bill that barely made it out of committee. A number of Republicans did not back it. You were one of the Republicans who supported that package. Why has there been such little support from Republicans in the Senate?
I'm not sure I agree that there's been such little support.
Well, 9 Republicans on Finance Committee didn't vote for the bill.
So if you're speaking of the final package, first let me say that my office had like 20 different amendments between the help and the finance package, all of which had bipartisan support, including other Republicans that were upon it. Okay? So there is broad support for addressing the issue. There was concern about some provisions, but if you look at the entire conference, I think those who had the most concern are concentrated on the Finance Committee. And if you look at the broader conference, I think that the majority of Republicans are going to support it. Why? Because we've got to lower drug cost. We've got to balance that with the ability to innovate and the incentive to innovate. And I think this package strikes that balance in that tension. It makes sure that there's an incentive to innovate, but that innovative drug can now be afforded. And if you balance that tension, you have a good package.
So on the House side, Speaker Pelosi has been vocal about her support for this package. On the Senate side, Leader McConnell hasn't said very much. He hasn't.
So if you haven't noticed, there's a few other things happening in the Capitol Hill.
Well, I'm a health reporter. I'm focused on this. But I think you have said this is a top issue. If there isn't drug pricing action, the Senate could be lost for Republicans.
First your sniffles, now the drug pricing. We seem to be. That said, I think if the House puts forward a package which is reasonable, which reflects that which passed on a bipartisan basis out of HELP and Senate Finance, then there'll be pressure upon both parties and both chambers to bring that to conference. The president is all in. He understands this is one of the ultimate kitchen table issues. So I think that brings to it. I don't think we should read too much into the fact that the leader is not bringing it. It may be that, the leader is never going to be effusive about very much except Louisville football. And so until something comes from the House, I'm sure he's just keeping his powder dry as he attempts to do that which we can accomplish.
Has Leader McConnell privately assured you that he's going to bring this soon?
He hasn't privately assured me, but I haven't sought that reassurance. And I know that Chuck Grassley thinks that it can come, and Lamar Alexander thinks that it can come. And I think that's probably a nice endorsement.
You're running for re-election
I am.
Next year. Do you think your constituents would understand if there's no drug pricing package from Congress?
My constituents understand that I'm sitting up here fighting for them on a regular basis to try and lower the cost of health care in a variety of ways, whether it's surprise medical billing or whether it is drug cost. And we have had successes. Again, the premise of your question is that we have not. But Maggie Hassan and I just had a bill which passed, signed into law, saving taxpayers $3.1 billion by closing a loophole that some pharma companies used to not pay mandated rebates back to Medicaid programs. Similarly, we passed a bill that the president signed into law last year that my office helped lead on to remove the so-called gag clause by which PBMs would not allow pharmacists to tell a patient it was cheaper to pay cash than to pay their pharmacy copay.
And PBMs, we're at a healthcare conference, but to be clear, those are the middlemen, the pharmacy benefit managers.
Correct. And so, and this was a contract that they would force the pharmacist to sign or else they wouldn't allow them into their network. So I think we can look at a track record both of striving but also of accomplishment.
We are at a healthcare conference. I looked at the sponsors for this conference, includes companies like Pfizer, Amgen, Genentech, collectively made, this is back of the envelope math, but at least $47 billion in earnings last year. Is that too much for pharma?
No offense, but that's a silly question. It is a silly question. And I don't mean to be offensive. Because
not offending me, and in fact, I think the room might like to hear why you think.
We're speaking about companies which are global in reach, which are a huge capital, which are incredibly innovative, which have investment that are not just selling at the pharmaceutical counter, What we really have to ask isn't if their profit is too much, but if the patient and the taxpayer can afford that which they produce. Now, if they are able to decrease the cost of the means of production, to bring innovative drugs that do have a greater value add, that they can therefore charge, but the system still saves money and patients can afford, my gosh, that's what American capitalism is all about. What you don't want is a system in which regulatory rules meant to encourage competition and innovation instead are arbitraged to artificially promote cost increases. That is wrong, and that should not be countenanced.
Well, let me ask a different version of that question. Are drug companies in America acting responsibly?
So again, people want yes and no answers here in DC. That is a more nuanced answer. If they're acting responsibly by investing in billions of dollars in a cure for Alzheimer's, which by the way has not yet come to fruition, but they continue to work towards that, yes, they're working responsibly. If they're arbitraging laws so that a drug which has been off patent for 10 years is being sold for $48,000 to Medicare Part D patients in the US when you can get it for $8,000 in Canada, they may be responsible to their shareholders. They're not being responsible to taxpayers and to patients. And so there's nobody who's like pure as the driven snow, and there's nobody who's evil like Black Bart.
Who's Black Bart?
That's an old cowboy, you know what I'm saying? I'm a little bit older than you.
Thought maybe he was a Democrat or something.
I know. You know, it's interesting because it's always the press trying to stir up controversy, you know what I'm saying? So,
Press is just looking for answers and clarity. Black Bart, right over my head. Let me ask you a question that's a little wonkier. It's about the Netflix model for paying for drugs. This is the idea that rather than a per prescription payment, state could hammer out fixed cost payment. You've done this in Louisiana. Washington State also has pursued this for hepatitis drugs. Can you give an update on the states that are interested in this model of pricing?
well, first to explain just a little bit, let me speak specifically to that. Let me answer your question specifically to Netflix and then to the broader issue, which I think is a broader issue which needs to be addressed. The Netflix model, so-called subscription model, just like you can binge on Planet of the Apes, you pay a subscription, you can watch as much Planet of the Apes as you want over the weekend, and then you stagger out of your room. So similarly, if you want to treat as many hepatitis C patients as possible, then you would pay a subscription, X amount of dollars for 5 years, whether you treat one patient or whether you treat 3 million, you pay the same amount. Now, I don't think Louisiana, in fact, Louisiana does not have a pure subscription model, but they do have one that dramatically lowers the cost and makes the drug more affordable. By the way, drug companies agreeing to this is part of being responsible. If you look at those patient populations which currently are not treated, they're typically incarcerated or they are on Medicaid programs, and those are the two that have fixed budgets and you cannot afford to treat at the commercial rates, so you're making it available at a less than commercial rate. I used to work in prisons, very familiar with the problem in the incarcerated population. This allows that to be addressed. So that's being responsible. There is a broader issue of how do we make these drugs more affordable? And we can now begin to speak about gene therapy. The Netflix model was published in JAMA. First author was Peter Bach, then Mark Trusham, and then I was on there. But there's also an article I have in Stat News on how do we pay for gene therapy. So you have a genetic therapy that is a cure for sickle cell anemia. Most of those patients are on Medicaid. And I'm a little rusty on the math, but imagine they charge $1.5 million. And imagine that we have, I don't know, 700,000 sicklers nationwide. We have more than that, but just imagine. Do the math. It's going to be trillions of dollars that'll be spent in the first 1 to 2 years. Now, we have to have a different way of thinking about this, because if you treat a sickle cell patient in the first year of his life, you will save $50 million in healthcare costs by the time he's 45. If you treat him when he's 45, you won't save a dime, because he already has the end organ damage from 45 years of sickle cell with heart failure and necrotic bones and strokes and you name it. So the value of that therapy is tremendous first week of life and is zilch at age 45. At what point do the two meet? So we need innovative ways to price Subscription models is one of those innovative ways. My Stat Cures article speaks about a few others. That is a discussion we have to have as a society.
And just circling back, states that are interested in doing this beyond Louisiana and Washington State, any?
And I apologize, I meant to answer that. And I'm not as familiar with others that are, but I do know that this has been presented by our Secretary of Health, Rebecca Gee, at the National Governors Association, so I suspect others will be.
Moving on to a different pricing idea, direct negotiation, allowing the government to directly negotiate. At the Finance Committee hearing this summer, you denounced the idea of empowering the government to negotiate on drug prices. I wrote the quote down, quote, "It would give absolute power to the government, and absolute power corrupts absolutely." Really?
Yes. Dan, is that something that is generational?
Have to ask Black Bart, but yes, it would corrupt.
So the government, let's just first speak conceptually, then speak in terms of the House legislation. The government's going to set the rules for negotiation, and then the government's going to negotiate. And imagine you have some demagogic candidate for the other party's presidential nomination.
Important clarification. Yeah.
Who's going to say, oh, we're going to get all these drugs for you for free. Venture capital is going to go out of that market so fast. Billions have been invested in trying to develop an Alzheimer's drug. So far, nothing has been successful. If venture capital thought there would not be an adequate return on this future Alzheimer's drug, why would they invest now?
Well, aren't there questions about whether investments are proceeding in Alzheimer's as needed? We don't have a cure to your own.
Well, to your point, it's been so fruitless that now some people are backing out of it, kind of making my point. And if you look at the House bill, much of which reflects that which passed in Senate Finance, but some of which I'm told there's a provision that would require the pharmaceutical company to accept the rate mandated by the Secretary of Health. And if the pharmaceutical company did not, then they would have to forfeit 65% of their gross receipts, going up to 90%.
95%, I think, actually. Yeah.
So if I need to give an example of how incredible short-sightedness on the pricing will drive away innovation, this provision being actively considered could not give me a better example. And if anybody thinks that private equity and others venture capital is going to invest in a drug for which the federal government may get 95% if you don't give them their absolute guaranteed low rate, my gosh, you're not from venture capital. I'm not from venture capital, and I know that.
You talk about an example, the example that this could be, it's a hypothetical. We have a real-world example of the government negotiating on drug prices. The VA negotiates on drug prices. Are you saying that the VA has been corrupted by that practice?
So I say the VA is only a small piece of an overall ecosystem in which the federal government is also purchasing through Medicaid, Medicare, and commercial is buying through commercial markets. The VA is a small portion of that. Now, to be sure, it is easy to imagine that there is an hydraulic effect, that if you drive down prices here, that prices for the commercial in turn increase. And there's evidence that that would be the case. Evidence from the 340B program. And so, but you can't extrapolate from the VA and assume all. But having said that, I will grant you, if the federal government goes in and says either you take this price or we're not going to buy it, the monopsony purchasing power of the federal government would allow it to temporarily drive down price. My point being, it also drives down innovation. And if the focus of this is, and as Esther was speaking, and she spoke of these cures that we need, everything we're speaking about is trying to balance that tension between innovation and affordability. And if you drive out any sort of ability to get return on investment, you drive out innovation.
I wanted to share some findings from a Kaiser Family Foundation poll. 70% of respondents said that drug companies put profits ahead of people. 65% of respondents said there should be more government regulation to control drug prices. I should add that the poll was conducted in February 2005, almost 15 years ago. Americans have wanted drug pricing action for years. Why has it taken Congress so long to catch up?
Congress has been acting on drug pricing regularly for years. And again, to reject the premise of your question, the Vaccines for Children program passed under Clinton with the Republican Congress, as I recall, which made vaccines more affordable. Mark McClellan is going to be one of your next speakers. He implemented the Medicare Part D program, the Medicare Part D program which addressed affordability for those on Medicare. There is the Hatch-Waxman Act, which brought in the generics. And so, yes, we have to have serial pieces of legislation, but that's because circumstances change. So again, Dan, I reject the premise of your question, which is that nothing is happening on the cost of drugs. And the last example I'll give is the one that Maggie Hassan and I just passed, which saves taxpayers $3.1 billion by closing a loophole. So, and 10 years from now, we will once more be working on drug costs because something different will have arisen. But things have been addressed in the past as well.
I've been watching, like any good Washingtonian, I've been watching the Nationals and the World Series. Hard to miss the average, yes, go Nats. I guess that's something worth clapping about. Local reporter, cheers for local sports team. But the impossible to miss ads running during the commercial breaks have been around things like surprise billing from doctor-patient unity. Healthcare industry has found a way to message against efforts in Congress time and time again. You're a lawmaker, you're trying to make legislation. Which part of the healthcare industry is the most fearsome when it comes to lobbying against the goals that you're trying to achieve?
So Machiavelli said,
also before my time,
that those who are going to benefit from change have not yet realize that benefit, therefore do not advocate. But those who understand that the change will negatively impact them understand that and therefore advocate against. That will always be the case no matter what. On surprise medical billing, that which you refer to, there is actors on every side of this who would like it not to happen because right now they're doing well with status quo. That includes insurance, providers, and private equity. So insurance saying, oh my gosh, private equities. No, insurance also benefits from the status quo. So what we have to do is not focus upon those that would push back, but continue to advocate for those, in this case, the patients, who don't yet realize the benefit that will occur and therefore perhaps are not advocating as vociferously as they ordinarily would. And I would argue in the case of surprise medical billing, the Cassidy-Hassan bill, the STOP Act, which according to CBO saves $17 billion, and which AHIP endorsed before later they got onto the current help version, is the one that would be respectful of everybody in the ecosystem. And we can talk further about this, the STOP Act, but I think it is the way to address this issue.
Last question. The panel that is coming after this one includes the current CMS Administrator, Seema Verma, former CMS Administrator, Mark McClellan, representatives from the industry. What is the question that that panel needs to answer in your mind?
How do we make healthcare more affordable while respecting the fact that you have to encourage innovation and keep doors open? Again, you can pay docs less than their value, less than their cost of doing business, and then they'll stop delivering babies and start just giving Botox for cash. And I use that example because that happens. Or the doc who's put enough money away and you finally defeat her and she just says, heck, I'll just go live on my boat and retire on my 401k. I'm sick of practicing medicine. Or the rural hospital that shuts down because now somebody can dictate their rates to them and they can't keep their doors open and we lose another rural hospital. There is no simple solution. It is an ecosystem. And I applaud those that you mentioned because I think they were respectful of that ecosystem, trying to respect how do we kind of simultaneously tamp down without tilting it in the favor so much in the form of one that others just leave the room.
I cheated. One more question. If you had to put odds on a drug pricing package happening by December 31st.
I'm an optimist, so I'm going to say 60%. But
not 100%, 60%.
Nothing is ever accomplished by a pessimist, but you also have to recognize the challenge. And so that balances my optimism with the fact that I know that every day I have to get up and work hard or else it won't happen.
Senator Cassidy, thank you for taking my questions.
Thank you, Dan.
Rejecting some others.
What's that?
Rejecting some others.
Oh, I didn't back any.